precision medicine, which is the future, not only in pancreatic cancer, but we have seen what it can achieve in different other cancers which we treat. So I'm just going to tell you what's going on in pancreatic cancer. Now, you just heard in questions and Dr. Shaila is saying that we do not have all these things, we are still sticking to CA 19.9. However, we are in the midst of a revolution, and maybe if we do the same talk after 2 years, I'm sure we'll have much more clinical data as well. So we all know how does things evolve in medicine. It's always bench to bedside. How do I move slides? Do I have a pointer? Okay, so it's all bench to bedside, right? And so we learn in the lab, and then we have to design smarter trials. And the reason why I say we have to design smarter trials is because of all the advances what we have made in this disease. If you look at in terms of the number of pancreatic cancers we are diagnosing, how many of them are actually long-term survivors? And this includes everybody who's going to have surgery, who's going to have radiation, who's going to have medical treatment. It's only 6%. And the main reason being that in spite of performing extremely good local treatment in only about 20%, still only a 30% of that 20% we are actually are long-term survivors. So we need newer treatments, right? And newer treatments is no longer just newer chemotherapy, because chemotherapy actually, if you ask me as a medical oncologist, it's kind of hit a ceiling because it's like just random bombardment of these cells with cytotoxic drugs, which is okay, it is effective, but only a small proportion of patients do benefit. People have tried to play around with the molecule which is already active, trying to make them more active. So like irinotecan, we make nanoliposomal, and it does make some advances, but not so much. So how do we move forward? If you want to defeat your enemy, you have to understand it better, right? And what I'm showing you is the classical photomicrograph of an adenocarcinoma pancreas in the first picture. The second picture is venous invasion. This is the reason why, in spite of a very good surgery, next visit you see lesions in the liver or lungs. Perineural invasion. A lot of patients, the first time they come to you is because they've had back pain. And back pain is because these nerves are infiltrated by tumor. And now we are also learning there's so much of crosstalk between neuronal cells and cancer cells. So where do they all arise? We all know these tannins, right? I won't bore you with this. But what's actually scary and what's also reassuring is that tannins are not uncommon. If you take normal pancreas, all of us sitting in the hall, if you donate your pancreas and a pathologist looks at it carefully, up to 60% of us will have tannins, right? But then all of them do not progress into pancreatic adenocarcinoma, and that's because in addition to that, can someone teach me how do I get the red pointer on the screen? In addition to that, you do need certain additional tumor suppressor losses, and the big fours here are these TP53, CDKN2A, and SMAD4. So, and in addition to these, and even if you look at these pannins, they do have predominantly KRAS mutations, right? And KRAS is a word you're going to listen for probably for the rest of the time in this talk, because if you look at how common KRAS is, in the past, if you read your textbooks, they'll say 80%. Now, today's literature will say 95%. It's not that KRAS incidence has increased, but just our ability to pick these up with this newer next-gen sequencing is much better than what we are picking up doing PCRs. What about the remaining 5% who do not have RAS mutation? Even in them, if you look, they have alteration in this MAP kinase pathway. So ultimately, without an alteration in this MAP kinase pathway, you do not develop pancreatic cancer. And in addition to this just alteration, you also have some copy number gains, and also depends on the allele in which your KRAS is mutated. There are multiple alleles, like for example, KRAS G12R is something which is not as important, as pathogenic as some other mutations, and therefore if you have a KRAS G12R, you'll also need in addition one of these three to develop this cancer. Now, as we speak, on the right hand side you see these are list of drugs which are targeting KRAS, right? And this is already 6 months old, and so each of these are developed by some certain companies, and they are kind of it's kind of a trade secret in pharma world, right? And it comes out only once they're kind of ready with phase 1, phase 2 data. But what I'm trying to show you is that just by learning to target this MAP, and for those of you who are trying to figure out what is this MAP kinase pathway, if you just look here, KRAS, and downstream you have RAF, MEK, and then you have your cyclin and CDK4/6. And so in other cancer, like for example lung cancer, we do have these drugs called sotorasib, adagrasib, divarasib. They all block G12C. Now G12C is uncommon in pancreatic cancer, but because we have these drugs already in the clinic, we have data to see these tumor samples, and we are learning when they stop working what happens. And in about 54% of the time, it's actually new KRAS mutation only which works. So basically just imagine, so if the tumor is dependent on KRAS, you block KRAS, and then it develops something else in KRAS for it to become resistant. So therefore what we need is, we need a drug which kind of blocks all of these, right? And we are getting there. So there are new RAS inhibitors. I mean, there are inhibitors, there are degraders, there are proteins. Now with the AI coming into this drug development, we can identify molecules much faster. We can take molecules which have greater potential into the clinic. Now, but what do we do with other patients? When I say other patients, that means not everybody. See, cancers are very heterogeneous, right? This is some data from RNA sequencing, and this is called transcriptomic analysis. So like in colon cancer, you all would have heard of consensus molecular subtype. Similarly, there are different groups have come up with different definition, but basically it all boils down to two groups: basal type and classical type. Just remember B for bad. So basal is bad, right? And if you have a basal, that also when I said heterogeneity, what do I mean? I mean that even within a patient, so this is the primary tumor, this is one liver metastasis, this is second liver metastasis, this is peritoneal metastasis. If you see blue is basal, and you see the liver mets are so enriched in RAS mutation, but the primary and the peritoneal mets are not. We always knew this in clinic. Patients with liver mets have poorer prognosis as compared to, say, lung mets, right? And now we understand why, right? So most of the liver lesions are basal, and they have a worse prognosis as opposed to classical. However, this basal is the ones who actually respond to RAS inhibitors much better. It's like, imagine like tumor cells being sugar high, right? And you take away this sugar, and then they are the ones who mostly respond. But as you would have understood by now, that it's not just one drug fits all kind of a thing. So if you do only RAS inhibition, the classical ones won't die. If you do only chemotherapy, the basal ones won't die. So you probably have to do it together, and that's what is happening now. And these are all clinical data where your chemotherapy is combined with this RMC 7977, which is actually a RAS inhibitor, and these are all in the clinic. So moving forward from chemotherapy, from RAS inhibitors to, there's another big thing called MTAP loss. Now what is this MTAP loss? It's not very uncommon, 30% of tumors can have. Basically this MTAP is a gene which sits right next to this CDKN2A or P16 gene. And once you have a mutation here, once you have a loss here, this MTAP is lost. And this is something you don't need a fancy NGS to pick it up. A simple IHC can do it in the clinic. And these tumors actually are sensitive to PRMT5 inhibitors. And again we have early phase studies already over, and then these trials are in a later stage settings. Now moving on to beyond the cancer cell, right? What is the importance of the surrounding, the stroma, right? We all know pancreatic cancers, right? The stroma is very different. It's not at all vascular. It's very hypoxic, and it is very immunosuppressive. And so much so that when you just use single agent immunotherapy, it doesn't work. Now, people say immunotherapy doesn't work in pancreatic cancer because there are no immune cells, but that's not true. With these single cell studies, you found that in the stroma, there are T cells, but these T cells are dysfunctional. They are just not able to come in contact with cancer cells and kill them. And probably major reason for that is the presence of myeloid cells in the stroma. And if you see, this is some work here again. If you see normal pancreas, we don't get so much myeloid cells. But if you see in the primary tumor and metastatic tumor, all these are myeloid cells. And now we know that myeloid cells, they do secrete different proteins which can actually impair T cell function. And at the bottom of the slide, there are some trials now where I have realized that, in addition to targeting with chemotherapy mutations, you also have to probably have something which target these myeloid cells. Also, it's been coming back to KRAS. It is also known that KRAS mutation cells, they produce a lot of GM-CSF, and this GM-CSF makes your tumor microenvironment very hypoimmune, and therefore the trials in the future would include this triple therapy. So you kind of block multiple cells at the same time, tumor, mutation, microenvironment, and that's going to be the future. There have been trials in the past targeting this stroma, right? What I'm showing here, this phase 3 trial was just, but then this was just, they assumed that the stroma is monolithic. They just was trying to just bombard the stroma with this PEG hyaluronidase. But now we know that even stroma, the myofibroblast, which predominantly makes the stroma, the cancer-associated fibroblasts, they also can be classified into many types. Some of them are inflammatory type, which helps the tumor. Some of them are myofibroblastic, which actually tries to reduce the proliferation. And now there are drugs which are kind of being designed. When I say drugs, it could be antibody drug conjugates, it could be CAR T cells, it could also be reprogramming these cells. So these were all about the RAS mutated cancers. Now, small proportion may not have RAS. This is where I think we should not miss these patients, because these patients do have targets, and all these targets which are listed on your screen, these drugs are available in India right now. It's just that we don't see them very often in your practice, because it's only a 5% of all metastatic pancreatic cancers. Some people say that if you don't have a KRAS mutations, you should actually doubt whether it's actually an adenocarcinoma or is it some uncommon cancer like an actinic cell carcinoma. But the importance here is, if you do not have a RAS mutation, your NGS panel should be extremely good in picking up these fusion genes, and which is, I mean, in India now every lab will say we are doing NGS, but they don't have, you need to figure out that they should be capable enough to pick this up. Now also there is a lot of works which says if you don't have a RAS mutation, these are more like biliary tract cholangiocarcinomas, not so much like pancreatic cancer. I'll just show you some data quickly, because I'm sure my time is up. If you have a BRCA mutation, you have these drugs called olaparib, niraparib, rucaparib, and they are all PARP inhibitors, and you see they are better than chemotherapy in this patient population. In ovarian cancer, in endometrial cancer, we also have this concept of HRD, homologous recombinant deficiency, which is conferred to the tumor not by just BRCA but also PALB2 mutation, and these tumors where PARP inhibitions can actually be combined with immunotherapy, and they can tend to do better. Now, MMR deficiency, all of us who treat colon cancer know what it is and how it's transformed treatment there. The same applies in pancreatic cancer. Unfortunately, it's just 1% of all pancreatic cancer. NTRK fusions. NTRK, again, these drugs work across tumor types, irrespective of which organ the cancer is arising from. And if you see the arrow here in this cohort of pancreatic cancer, if you use this larotrectinib, entrectinib, these drugs are available. You just have to pick this fusion, but it's like picking a needle in a haystack, but you shouldn't miss it for your patient. RET fusions, selpercatinib, this is again a drug commonly used in thyroid cancer, lung cancer, but even in pancreatic cancer, if you see here, about 6 patients were there in this series. Okay, now coming back to RAS. Now I just can't get enough of RAS, because you remember Dr. Shailesh also was talking about vaccine. This is a very exciting area. So what are they trying to do? So basically 2 ways you can use vaccines. One way is, if you have a patient who is extremely high risk of developing a cancer, right? You have these vaccines which kind of bind, which are directed towards all these RASes, which are important players. And this is again lab work, but they're trying to show that if you have these, if you can get the T cells up, and these specific T cells remain in your body actually for years, and you can prevent a development of a cancer. But then we all clinicians, we want randomized trial, we want phase 2 trial. So here again, if you see, this is again, this just got published last month. So this is again a mutant KRAS specific vaccine, which is given to all these are all patients who have had Whipples. They are on follow-up. You do cell-free DNA and you find some tumor DNA in the blood. So they are at very high risk of relapse. In these patients, when you give these vaccine along with immunotherapy, and then you see, depending on the immune response and patients who have had the response versus patients who have not had the response, you see a very good difference in their survival. So there is good enough and more signals here that very soon, not only in pancreatic cancer but across different cancers and solid tumors, RAS is no longer going to be an undruggable target, and we are going to have a lot of developments in this area. So I know there's lots to digest and take. You guys can, actually I can share my slides with all of you, or if you can just take a picture of these two nice reviews and read when you have time. So thank you for your attention, and I hope I was useful.
It was very interesting to hear you, Dr. Ashish. I think I have seen some of your patients who you have been able to handhold and take them to recovery. Happy to see you also. I talked with you earlier. I think Dr. Matthew Philip, you will have longer experience on these patients. Pancreatic malignancy, your views?
I am so happy to hear Ashish for this wonderful talk, because whenever we talk to our patient about pancreatic cancer, surgery, borderline resection and all, actually we feel we definitely have a depressed phase, and we know that what we are going to face. But recently I have noted that there is something, a silver line coming up in the cloud, and I'm so happy that the vaccines and drugs acting at different level. And many times what we have noted that chemotherapy is only just like a blanket type of chemotherapy. Now it is actually molecular level and targeted therapy. And I really think that this is the precision medicine which really made the difference. And I'm sure that, as you told, after 2 years, when you stand and tell about these patients, the story will be different. That's what I think.
We should be thankful to our pathologists, our molecular biologists, who are actually able to get all this information from us. At the same time, people in the lab who are designing these drugs. Again, it's a real bench to bedside story, and I hope that even India as a country, we are able to kind of get these things to our people faster, and we all learned this during COVID, right? Like if there is a will, we can do it. Because the elephant in the room is going to be the cost and the price and the access. As long as we're dependent on the West for all these things, I think it's going to take a long time. So all of you young people in the room, I think there is a lot you can do in this area. Thank you.
Yeah. Can we have one more question? Yeah.
Sure. Excellent talk, sir. From your talk, I understand even in a single tumor of pancreatic cancer, there are multiple molecular pathways are involved. Then how do we choose targeted therapy in that case?
Exactly. So all cancers are heterogeneous, and this heterogeneity evolves from time to time. Like we all, I told you, like 60% of us sitting in this room can have pan-ins, right? So in a way, all of us are having precancerous lesion, right? And from here to development of a cancer, to surgery, to metastasis, to first-line therapy, second-line therapy, tumors are changing every moment, right? Mutations are occurring. And the reason why we haven't succeeded so far is just blanket one treatment thrown at one tumor. So we need to learn about the tumor in real time. So somebody who's had a Whipple's done 3 years ago, today has a liver metastasis, and I'm doing my molecular testing on the Whipple specimen, I may not get the picture. Understand? And therefore, and whatever I was saying, that we need chemo, we need RAS inhibitors, we need some immunotherapy, we need drugs which can work on the myeloid cells, we need drugs which can work on the stroma. How do we combine? And this combination, is it going to be too toxic? Is it going to be too expensive? The field is moving forward. Even in the monoclonal antibodies now, you say you have bispecific, you have trispecific. So if you know the target, you understand the thing, you can design an antibody. With the ChatGPT era, ChatGPT will screen through multiple molecules and tell you, take this forward in the clinic. So it's an exciting times ahead.
So will stem cell therapy in future replace the genomic sequence in a targeted based chemotherapy, sir?
Of course, ma'am. So our treatments are going to be more and more I shouldn't say targeted, more and more precise, and I don't think one treatment will replace another. It's just that it will be a design package for that particular tumor, for that particular patient. And if you need chemo, we'll have chemo. If you don't need chemo, we'll not have chemo.